Thank you so much, everybody being here, and we're going to start it off in prayer. And I've asked Jeff Breedlove to open us up in prayer.
Mr. Chairman, thank you, sir. It's a privilege. Father God, let us pray. We are a strong and wonderful state. We are a diverse state. We pray for your blessings on this committee and this hearing today. We pray for discernment for the leaders who will hear from the people, that they may be guided with grace and compassion and wisdom, justice, and moderation for the people of Georgia. As we gather here in our capital, I know we stand united in remembering those around the world in the midst of conflict, and that we pray for safety and peace for the people of the Ukraine. The burdens we face are many, but they are nothing compared to what they're facing. So, Lord, just bless this gathering today, and thank you again for our leaders. In your name we pray. Amen.
Thank you, Ms. Breedlove. So we have House Bill 1013 today, and let me just sort of give us sort of the game plan with this. We're going to have a general overview today, and with testimony, and then we're going to, obviously tomorrow is crossover day, so it'll be sort of a busy day, but we're going to, on Wednesday, we're going to have a subcommittee meeting at 2 o'clock in Senate, in the mezzanine 1, and then on Thursday we're going to have another subcommittee meeting at 1 o'clock here in this room, and we're going to do testimony at that time too. So if you don't get to speak today or others want to speak, we'll continue to have that. And just another aspect, so a general overview today, and then we're going to follow up. We're going to sort of break the bill up into sections and address particular sections that we need to, and then we'll reconvene as the full committee, and then go from there. The subcommittee is going to be 2 lawyers and 2 doctors. So Senator Burke is going to chair that subcommittee, and we have ex officio Chairman Brian Strickland, who has joined Health and Human Services, and then myself will be on the committee, and Senator Kennedy also. So that's how we're going to do it, and thank you for bringing this. I was about to say Senator, apologize for that. From your perspective, Representative Mary Margaret Oliver and Representative Todd Jones, thank you for being here. I will let, I don't have a fast rule on this, whether y'all want to be at the podium or if you want to be down here at the witness chairs, and we can do a general overview, and then we're going to have testimony. You know, I remember my psychiatry professor at medical school told me that if you had people's attention, if you tried to hold it longer than about 20 or 30 minutes, you lost them. So I'm not going to hold us to a meeting of 20, 30 minutes, but it's been a long day, and we have a long day tomorrow, so we're going to try to hold this to an hour. And again, we're going to have subcommittee testimony, and we're going to have, which will be at least 2 days, and then we'll have the full meeting that we'll follow up with. So once y'all have a seat here and bring us up to date, and talk to us about Senate Bill 1013. Sort of close to you, and because they.
Chairman Watson, members of the committee, thank you so much for your time today. We are proud to present to you a bill that is sponsored by Speaker David Ralston. Representative Oliver and I have been called his co-pilots, one from the Republican side and one from the Democratic side. It has been a great working relationship with the representative, and I've appreciated definitely the collegiate way that we've been able to go through this so far. In terms of, I tend to agree with Chairman Watson, other than the fact that instead of 20 or 30 minutes, we're going to try and do this in 10. Now, an 80-page bill in 10 means that we're going to stay pretty high level, but our understanding is there's going to be a deep dive during the subcommittees. And that doesn't mean we're not willing to take questions, but we understand that the intent of today's meeting is to stay high level and then get testimony from the public. And we want to basically line up with what the chairman would like to achieve today. I want to go ahead and speak for just a few minutes and give you a very quick overview of 1013, and then Chairman Oliver is going to give you kind of more of a historical perspective, including the commission, which I'm sure many of you know was appointed by the governor, lieutenant governor, the speaker, and then also the Chief Justice. A lot of folks forget that the Chief Justice had an appointee to the commission. And then from there, do a little bit more of a deep dive on the sections, and then at that point, then Chairman Watson, we think that we hopefully will have covered at least the high parts of it, and then at that point, obviously, the discretion of the chair. But taking a look at HB 1013, clearly this was something that was in the making for over 2 years. This was a commission that was put together in 2019, chaired by Kevin Tanner, who was my delegation mate out of Forsyth County, and he is still the chair of that committee. HB 1013 does extend the sunset, by the way, on that commission. That's not a detailed part of the bill, but at least I hope that you know we felt as if the commission worked so well that we thought that 1013 should extend the sunset on that commission. Chairman Oliver will talk a little bit about all the different task force and the different committees that come out of it, but I can assure you one of the things that we want to do is streamline. Ultimately, 1013 really comes down to a fundamental fact that notwithstanding all the efforts of the folks within all the different agencies that we have at the state level, and I can assure you, I believe that their efforts are true, and I do believe that they have a good heart. But unfortunately, no matter how you rank mental health and substance abuse treatment here in the state of Georgia, the only conclusion you can come to is the fact that we, let's just say, are very poor at it. Some rankings put us as high as 45, other rankings put us as low as 49. Either way, I don't think it's where we want to be in any type of ranking. And so ultimately, first and foremost, acknowledging that there is a challenge within how we handle mental health and then how we handle substance abuse. My son, my oldest son, unfortunately, he has helped his mother and I experience this system for the last 8 years. My son is dual diagnosis. Thank God, no more substance abuse, but definitely on the mental side, the doctors have basically said that he has the cornucopia of basically everything. It may be bipolar, schizoaffect, depression. We can keep going, but we're not here to talk about Justin, but rather we've been able to see the insides of the system. We've been able to see exactly where the system does not run well, and unfortunately, that's pretty much everywhere. I wish I could tell you that during our 8 years that we could tell you, you know, there's this one shining light. But unfortunately, there isn't that shining light. There's a challenge across the board, because I can say this, there is not a get started here button. And I know that sounds weird, but I think when you are a family member, or you have a friend, or you're trying to struggle with how it is that you handle this, a lot of us have never even experienced someone with mental health or with substance abuse, and then suddenly you're thrown into, how do I help this person? I want to help this person. You go out, you think it's on the website, or there's an app, or there's a 1-800 number. There isn't. There isn't even this is the first step to help your friend, your sister, your daughter, your son, your aunt. So ultimately, when we started to think about HB 1013, granted we didn't have a bill number yet, but when we started to think about how we're going to solve this, I think one of the things that we need to acknowledge is we have too many people caught in what I call as the chronic system, or the chronic cycle. 3 to 5 days of acute treatment. I call that the time where they drug you up so much that basically Secretariat couldn't run around Belmont. I watched my son bang his head against a wall so hard that blood's coming down his face, and they're telling me, you know what, he's ready for step down. I'm not a doctor like Dr. Watson, and I didn't stay at a Holiday Inn last night, but I know this, if someone's banging their head against a wall with blood coming down and they don't realize it, I don't think they're ready to be stepped down yet. I don't need to have an MD for that. But ultimately, maybe after the acute phase, or then the 30-day traditional step-down phase, and then you're out. And we know that that just does not work. And we know it doesn't work because I think I can speak for Chairman Oliver and I, just in this building alone, in the last 4 to 5 weeks, we've had more people walk up to us, may it be members of the General Assembly, lobbyists, stakeholders, constituents, you name us, with the following line: can I get a second? And I'm telling you, it isn't to tell me about line 1,000 of the bill. It's to tell me about, right? It's, oh my God, you're speaking to me because my fill in the blank has the same problem, or my fill in the blank, and this is going to mean so much to us. So we understand that we not only have to do the right thing in terms of the passion is one thing, but the speaker always reminds us it's also good policy. So let's get into that real quick. We hope that what you hopefully been able to review all 80 pages, you see that we have broken it down in such a way that it's parity, MLR, and I'd like to give a shout out to Dr. Newton on the House side. He calls it the medical spend ratio instead of medical loss ratio. I got to be honest, I kind of like that acronym better than MLR. But you got parity, MLR/medical spend ratio. And then we get into very specific parts of the bill in terms of maybe AOT, workforce development, the different commissions, tasks, et cetera, and then, of course, the judicial system in terms of how we're going to run this through. I don't want to take any of Chairman Oliver's thunder, so I'm going to let her go ahead and give you all the details there. But I think what you're going to find is we hope that we have provided the Senate, and frankly the entire General Assembly and the governor, a way to look at the bill that it really is sectioned off really nice. So maybe the co-responder section, maybe the MLR section, maybe the parity section. We can really look at these things really as a subset within the total omnibus, as opposed to there being a significant amount of cross. Now granted, definitionally you're going to see a lot of cross in terms of what's happening with insurance and Medicaid, you will, but we hope that you've noticed that we have tried as hard as we can to create chimney stacks so that we are able to speak to certain sections as we're speaking to certain subjects. So with that, I appreciate the attention. I appreciate you giving us this time, and I'd like to turn it over to Chairman Oliver so she can go give you a little bit more of history and a little bit of a deep dive.
Thank you, Dr. Watson. I'd like to begin a discussion about my involvement in this bill with a recognition that it's a privilege to work on legislation that has real impact for Georgia citizens. I know through 100 different ways, as I think you do, that mental health impacts Georgia's families, and that we have made progress since Milledgeville was the largest, and the term then was asylum, on the planet, with 12,000 mentally ill folks cornered off in a portion of that county on the Milledgeville campus, but there's a long way to go. I think a history of the Behavioral Health Reform and Innovation Commission and a history of the process that we've gone through in the House might be helpful to the Senate members to see each step as I believe we have improved the product that we bring for your consideration. When the Behavioral Health Reform and Innovation Commission was initiated by then Representative Kevin Tanner, I began a campaign to be appointed to it. I had worked with Representative Tanner in the previous Transportation Commission. I knew his work ethic. I knew his method of bringing people together. I really had a tremendous amount of respect about how he used resources to come forward with very substantive legislation, and I was successful. I have handed out for the committee members the names of all the folks that were appointed by Governor Kemp, by Lieutenant Governor Duncan, by Speaker Ralston, and Chief Justice Melton. In the Lieutenant Governor's appointments, Senator Renee Underman has been replaced by Senator Brian Strickland, I understand. And as each of the committee appointees, you'll see we have law enforcement folks participating significantly. The commission organized itself under Kevin Tanner's leadership to work in subcommittees. Dr. Brenda Fitzgerald, who is Lieutenant Governor Duncan's appointee, chaired the subcommittee on a parity. The subcommittee process was very unique in my long legislative career. They met separately, independently, and relied almost exclusively on experts who came forward to the commission. The only legislators are the senators that I've named, and then on the House side is Representative Don Hogan and myself. The subcommittees, working independently, came forward with a recommendation end of 2000, beginning of 2021, and in the 2021 session, 2 of the recommendations of the commission were passed into law. House Bill 302, authored by Chairman Sharon Cooper on telehealth was passed with, and is a very good bill. When we reviewed the telehealth legislation as we came forward with new innovations, we recognized that it was a very strong bill. And the second bill, authored by Representative Hogan, was House Bill 590, which expanded the authority of family counselors to participate in certain 1013 evaluations. In May of 2021, Kevin Tanner reconvened portions of the commission and put together a work group to start developing a bill. And the bill came forward throughout the summer and fall and began to be circulated to all the agencies involved. Kevin Tanner and I went and sat down with the insurance commissioner, and we've met multiple times with Commissioner Judy Fitzgerald's staff. We have, in each way that we are working forward to take down the silos and to give more responsibilities to agencies, we have worked with the specific agencies themselves. The first hearing the bill was introduced by Speaker Ralston January 26th, and we had 3 hearings. There was probably 5 to 10 amendments offered at each of the public hearings that we had, and we have in each way improved the bill. Let me give you a couple examples of the amendments, and then I'll go back and go through the sections. There are a number of different councils and commissions and task force in this bill. They have been previously statutorily created. They're not new. For instance, the Office of Health Strategy and Coordination that the Senate had a particularly strong role on is enhanced in this bill, but it existed in previous legislation. The Behavioral Health Council was initiated 4 or 5 years ago, and in different legislative enactments over the last year, I'll use this as an example, the prescription formulary mandate was given to 3 different agencies. It was given to DCH. I think primarily it was their duty, and they haven't done it yet. It was given to the Behavioral Health Council, and then it was given to the Office of Health Strategy and Coordination. And in this bill, we have centralized that in the Office of Health Strategy and Coordination. Kevin Tanner's discussions with the governor over the summer and fall gave us encouragement to make the process of who's in charge of developing certain principles and proposals and programs in a more centralized way. If you give the job to 3 people, it's less likely it's going to get done. If you give it to one person and acknowledge his or her authority, there's a better chance that it'll get done. So we've thought about that in terms of the amendments, and I'm sure there's more streamlining we can do. I have shared with Regina Quick in multiple meetings some of the background work we've done on these councils and task force. The issue of parity in Section 1 and the definitions that specifically began around line 58 is not a new discussion either. In the Bush administration, over 20 years ago, there was principles set forth of parity, that mental health illnesses will be reimbursed in the same way that physical illnesses. In the Federal Parity Act of 2008, that was strengthened. At the end of the Trump administration in December 2020, there was another set of enactments that gave specific responsibilities to the insurance commissioner of each of the 50 states. And if you look on Section 1 about parity and begin on around line 57, you will see that the definition of enforcements of parity provisions are based in part on a more specific set of definitions of mental health services that are appropriate to be delivered and appropriate to be paid for. This is a national discussion that's been going on in recent years because although we have believed in parity for a long time, we have been very slow to move forward to make sure that it can be enforced. And the definitions of Section 1 relating to parity give us tools for enforcement. Some of the language of these definitions comes out of a case that was decided in a year 1 to 2 years ago that said to an insurance provider, federal court case, your definition of mental health services is simply too vague and gives you too wide an authority or too ambiguous a set of principles in order for parity principles to be enforced. So the definitions that come forward based on this national discussion are based on the real demand that people have, and I think the appropriate policy consideration that parity be accomplished and it be enforced. Another part of the parity enforcement in Section 1 relates to a more robust and a more meaningful consumer complaint process. I have met with the Office of State Office of Hearings and Appeals because they do Medicaid eligibility hearings, and we have coordinated with them and DCH in relation to this consumer complaint process that will give us a better opportunity to find out where the principles are. The most important duty that we're given to the insurance commissioner newly, based in part on the federal enactment, but also our intention to apply parity enforcement principles to all different health care providers, is for there to be a data call from insurance industry to figure out what they say they're delivering in terms of mental health services. Again, without these tools of specificity of definition, without data collection, without a consumer complaint process that is meaningful, we cannot expect to move forward. So at this point, we expect to move forward. I have learned a great deal about the concept of medical loss ratio. And since I was an English major in college, I'm not going to try with a whole lot of detail to try to explain and I prefer Dr. Newton's definition too of medical spending ratio, what it really means. But basically the law is, and has been since 2012-ish, that 85% of the premiums received by CMO shall be spent directly on medical services. I don't believe Georgia's in compliance with that, nor is Georgia in compliance with the majority of how states calculate the MLR calculation. And I will tell you that the difference in 1 percentage point, if it's just 1 percentage point, difference between 83, 84% is almost $100 million. So the opportunity that we have now, and the obligation, more importantly, to the taxpayers of Georgia, is that our MLR determination be appropriately in line with national standards, and that we consistently move forward to make that happen. As you may know also, this is a little bit tangential, but it's not totally tangential in my mind. There's a major lawsuit going on right now against Centene in the pharmacy benefit area where Georgia is participating in that lawsuit, and there is over $50 million been settled with Ohio, over $50 million settled with Mississippi. And Georgia, the newspaper, the national newspaper on this story, is reporting that Georgia's settlement has not yet been completed. So you see the MLR and the spending ratio and the formulas that relate to the CMOs are very hot right now, and very much appropriate for us to turn our attention to them as a way for Georgia taxpayers to get more benefit from the money we are spending. Section 1 and therefore covers the very significant parity and MLR. Section 2 begins a real excellent dive into workforce issue, which every state agency and every employer is struggling with right now. We're creating a new education loan forgiveness program for an allied, more extensive list of allied healthcare professionals to have an opportunity to have their education loan forgiven if, and this is consistent with amendments that we've made. Representative Jones has met with the student finance Lynn Riley extensively and given her authority to say has to be underserved, has to be somebody who is ready to deliver services, and in fact somebody who will accept. We're obligated to ask, I believe, under this bill, will you accept Medicaid? Will you accept Medicare? Those are the kind of questions that we should have before we decide to cancel a loan. I think that's a very important, strong new benefit that will be meaningful in helping us develop a greater way to deliver services and enhance our workforce. Section 3 is assisted outpatient treatment. This committee has been chaired by Judge Amero, and he has been actively involved in the developments and the promotion of mental health courts and new ways that we use the court system and other oversight systems in a way that we can deal with the folks of our mental health system who are really struggling, the folks that are in jails repeatedly, in ERs repeatedly, in crisis units repeatedly. We know over time, I believe, because I have served as a county conservator for over 25 years. I have managed the money and some of the lifestyle issues for mentally ill and incapacitated adults as appointed by the probate court. I have been a conservator for folks who, for the most part, live independently with a little bit of money, sometimes a lot of money, but mostly it's a little bit of money. And they have the support generally of a loving family, a family that can't be bonded to do the money part, or a family that creates too tension in the family if you're handing out the checks. So the tension comes to me. I'm the one that hands the check out or not hands the check out. It's these folks live independently and they are not violent. They are not violent. One of my wards was murdered by his caregiver 2 years ago. I had to go testify in Clayton County. He was a veteran. Frequently I've had veterans in my caseload. They are not violent. They are victims of violence. And they're victims of scams, and my job sometimes is to try to protect them from the people out there stealing money. It is a very small percentage, but it is a significant percentage of folks that are significantly mentally ill, not managed, and are clogging up law enforcement, clogging up ERs, clogging up crisis units that we do not have enough of. And the AOT program is really designed in a innovative way that's been very successful in other states to address the issue of the repeat familiar face in and out of the court system. It's not a super large number of people, but it's a super expense to our system. Along with that program, another new innovation that you have been very involved in is passage of Senate Bill 403 and co-responder programs. In my district, Brookhaven, not with the CSBs, some of your programs are CSB programs, but in Brookhaven, the police officers, Brookhaven and Forsyth County, all of Forsyth County, along with dozens of other, have organically grown up co-responder programs. And the bill, in a variety of ways through the Criminal Justice Coordinating Council, chaired by Jay Neal, are helping fund some of those new efforts. These are ways that we can, again, give some relief to law enforcement, give some opportunities for additional services. The question I've asked everybody in the co-responder world is, what percentage of your 911 calls, soon to be 988 calls, what percentage of those calls are better served by a mental health professional going out with law enforcement? I'm always consistently surprised at how high that number is. Between 30 and 60%, people will tell me. And when we have a variety of co-responder programs going out, funded, where we're getting data, we'll learn what is the best format for that. Sheriff of Fannin County told the speaker that 60% of his 911 calls were family-on-family disputes, which are very, very consistently tied to substance abuse and mental health. I think I'll stop at that point and give Chairman Jones an opportunity to expand and correct and emphasize what I have not emphasized significantly.
No, I think Chairman Oliver hit it, and so Chairman Watson.
Thank you so much. We appreciate that overview. And for those late arriving members, I was actually supposed to be where they was in judiciary, but I appreciate y'all. Actually, the four sitting to my left here were filling in for me there, and thank you very much. So what we're doing today, just so everybody knows and doesn't hurt to repeat, that we're doing a general overview. We're going to have some testimony, and then on Wednesday and Thursday we're going to do subcommittee and do a little bit deeper dive, and we're going to continue to do testimony. We're going to continue to work and perfect if we need to as we continue to learn about this, and then we're going to reconvene after that. So as crossover is there are 180 of them and there are 56 of us, so generally that's a few more bills bills on that side for us to digest, and so we're starting here before crossover. And as I just came from House Health and Human Services with SB 403, and this has been a speaker-led, and I didn't give due credit to the Lieutenant Governor and President of our Senate, Jeff Duncan and Regina Quick, and their office, because that is their bill, and Senator Kay Kirkpatrick's had a parity bill also. I do not look at these as mutually exclusive. That bill is, our bills are good, your bills are good, and we'll continue to work together on this. I've been here 4 years in the House, 8 years in the Senate. I think you may have been here a little bit longer than I, and maybe a few others too. But the point I was trying to make is that we've been doing mental health bills since from the very beginning, and this is not the end all. We're not going to cure mental health by any means, and we come back and fix bills as we see fit, and we're going to continue to do mental health, and but I think this year is a major step. Having said that, I'd like to see if the committee has any big picture, 30,000-foot view questions. Then I'd like to have some testimony, and then we're going to do a little bit deeper dive in the subcommittee format. Does the committee have any questions? I see none. So we're going to start with the testimony. What I'd like to do is just, we have, did you count these? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. We got 13 that would like to testify today, and we'll give you at least 3 minutes with that, and we'll have a follow-up question from that perspective, and you can see that will probably run over our time, our goal, but that's okay. Rhonda Thomas is going to be first, and if you wouldn't mind coming up to the podium, and just if each one of you would identify yourself, who you may or may not represent, and if you are in favor or opposed. I will say we're going to keep this all genial today. I don't have the Capitol Police outside the door, but I don't think I need it today. So
thank you for that.
That is much appreciated.
Let's stay calm.
Thank you, and Ms. Thomas, the floor is yours.
Thank you. I'm Rhonda Thomas. I'm representing several thousand parents here today. I have a group called Truth in Education. So we have a lot of concerns about this bill. If I were to say today, I would say I'm totally against the entire bill. I hope it dies in the Senate. But I am open-minded, so I'm willing to learn more. I want to see what someone can share with me that are the good parts of this bill. So one of the things I'm concerned about, because I am working in education, is this aligns totally and really mirrors social emotional learning. And social emotional learning and this mental health bill are all about behavior change, which is a good thing. We all want that. But mental health and mental illness are two different things. Mental health belongs to the parents and the family. Mental illness is totally different. And I see we've already got ICD codes putting mental health underneath psychiatric care. When you start using those codes, you are opening it up to anything can fall underneath that. So that is a very big concern. This is creating the framework for whole child, whole community that has been in the works for quite a long time. You can find it on the CDC, the DOE, on every DOE's website, including globally. You can find that in China. So this is a global agenda, but we're really concerned about Georgia. And the whole thing about Georgia, this bill aligns with the whole child, whole community because it's about moving the family out and bringing in every organization possible to surround that child to meet their whole needs, their psychological needs, their health needs, their nutritional needs, any need there is. So who determines that that child needs those who specifies what those needs are. So under universal, we're doing universal mental health screenings on our children right now in our schools. I have a letter from a Board of Education member who sent the letter that went out to the high schoolers along with the screener that they use. Well, it aligns perfectly with CASEL, which aligns with Whole Child's Whole Community, which really blends right in with this mental health bill. It says under Whole Child, Whole Community, one of the questions you're going to ask that child is, do they demonstrate honesty and integrity? Well, the screener this teacher had to use to rate their students, these were the questions. Do they steal? Do they lie? Do they cheat? Are they depressed? Do they have anxiety? Are they behaviorally flat? This all leads to mental health. I would say that child would be labeled with mental health, right? There's nothing positive asked on any of these surveys that our children are given in schools. I was here several weeks ago when there was a mental health press conference. I recorded it. You could hear the answers to our children's surveys in those in that press conference. So our data is going out to third-party individuals or organizations. And then you're going to add the data from this to that. There is no one that won't fall under mental health. So we're very concerned about that. Why are we asking our teachers to live up to something they're not prepared for, and that is to work with our children when it comes to social and emotional health? Our counselors now are considered professional counselors instead of guidance counselors, which they're not qualified for. But the question to ask is why? Is that because they'll be able to file Medicaid possibly down the road? There is so much involved in this that we need to decide who's in control of our children. We are very much for helping the people in need, but we don't need a 74-page bill to do it. We don't need all these new organizations. We need to create that 800 number and the things that are truly needed for the people in need. Thank you.
Thank you very much, Ms. Thomas. So next is Ms. Robertson, and then Jeff Breedlove is in the chute. Okay. So we went a little bit over the 3 minutes there, but we're trying to be generous today. And what we'll do is, if you introduce yourself, and just for the committee, what we're going to do is we'll hear testimony, we'll circle back, and I notice they're taking notes, and then we'll go from there. Yes.
Mr. Chairman, if I could ask something, one of the things that we asked in the House when people were giving testimony, if they could follow up with an email with specific line numbers, because it is an 80-page bill, with specific line numbers of their concern, that would help immensely, as we did 158 amendments in the 4 or 5 weeks we had it, and it was helpful to be able to get that information. So,
that is a great suggestion, and I should have said that from the very beginning, that we would love to have Ms. Thomas Robertson. If you have written testimony, we're certainly happy to take that. And I do see you left your email. Ms. Thomas did not, but we will either through Representative Jones or myself or the subcommittee chairman, Dean Senator Burke, that our emails are just all you have to do is Georgia General Assembly and Senate or House, and they're publicly available, and we'll receive those. The floor is yours, Ms. Robertson.
Thank you. My name is Gina Robertson. I represent a group of about 1,700 parents in Cherokee County that's been fighting a lot of this that's been going on in the school systems. A lot of values that we don't feel reflect the values in our community. I echo a lot of Rhonda's concerns. Our biggest concern that we've been fighting is a lot of the surveys and assignments that are coming in. Are data mining our students and are profiling them as well. We've had a big push for SEL, which is social emotional learning, in the past 2 years. That's been a huge concern. The surveys that we've used are Panorama, which is CASEL's chosen platform, which is where SEL comes from. Panorama was marketed by Bill and Melinda Gates, the Chan Zuckerberg Initiative. If those names mean anything to you, that was a concern of ours. Merrick Garland, the U.S. Attorney General, his son-in-law is the CEO of Panorama, and he was the one who targeted the parents at school board meetings, if anybody remembers any of that. So this bill feels very overreaching to us. It's concerning to us when we're giving the WHO control over disorders, using that kind of language. It's all very, very concerning as far as giving overreach to these government organizations to things like involuntary confining, somebody taking away imminent personal harm, those terms when somebody has suicidal thoughts or things like that. Our own county has formed a merger with DFACS within our school system as of last August. So all of these are concerns that we have with the language, and it feels very, the language just doesn't feel very, it feels very generic. And so those are just all big concerns of ours and all of our parents in our group. So
Thank you very much. And you did reference some specific lines, so if you just would follow up with that, would be much appreciated. Thank you very much, Ms. Robertson. Jeff Breedlove, I don't have any trouble pronouncing your name there.
Yes.
The floor is yours.
Thank you, Mr. Chairman. Lord, give me strength. I'm Jeff Breedlove. I'm a person in long-term recovery from substance use disorder. I work for the Georgia Council on Substance Abuse, and that's who I'm representing today. Two numbers, 2 and 14. We're going to talk about those two numbers for a minute, 2 and 14. For 2 years, Georgians of good faith, a diverse group of Georgians, began working after Governor Kemp and the General Assembly, in their wisdom, passed a commission. This commission met through the pandemic. The pandemic did not stop the work on mental health and substance use disorder. Over 30 citizens groups that you know and trust, groups that are here working with you day in and day out on policy and legislation, support House Bill 1013 as passed by the House. 2 years, those 30 groups met every Friday. Arguments, tears, shouts of joy, hugs, lots of emotion, but work with integrity went in a diverse coalition, a statewide coalition, who represent tens of thousands, if not hundreds of thousands of Georgians and their families. 14 years. I'm not a lawyer either. I heard it in one of the committees today, and I didn't stay at a Holiday Inn Express last night either, but I do know there's nothing in the Georgia Constitution that's conservative or progressive that says the state of Georgia won't enforce federal law for 14 years. This is a time for choosing. There will be people during the course of this discussion that will say parity is being enforced in Georgia. There are people who testified in public in the House who said, oh, we're for parity. We just need some, quote, more time to work it out. That was public testimony. It's not about you working it out. It's about enforcing federal law. 14 years. There's nothing conservative or progressive about the fact that Georgia families have been denied services we're entitled to under federal law for 14 years. We need strong parity language to send an unmistakable message to every person in the state of Georgia that we are going to have meaningful parity. Let me end with this. I saw the 30-second sign.
Thank you, Ms. Breedlove.
Let me,
sorry.
I said, let me end with this. I mean, one more
I'm
point.
sorry,
One more point.
I jumped the gun on
Sorry,
you.
one more point. With due respect to others, I don't know what some global agenda you're talking about. People of good intent, of good faith, who've been working on this for 2 years, are trying to save the lives of people like me. So if you want to know what's good about this bill, as a peer, I'm what you're talking. I'm who you're talking about. Me. And my brothers and sisters. Is this bill perfect? Of course it's not perfect. Does it need to be perfected in the Senate? You bet it does. But it's a bipartisan bill that had 190 plus votes in the House. It's got a historic coalition of citizens groups, the largest in modern times, working on a mental health and substance use bill. This is a common sense, bipartisan bill that's going to save. So you want to know what's good about the bill? It'll save lives of people like me.
Thank you.
Thank you.
Thank you, Ms. Breedlove. We appreciate that. Didn't mean to cut you off there. Kim Jones with NAMI. And floor is yours.
Kim Jones, Executive Director of NAMI Georgia, also the proud mother of a child with a mental health condition. And I'm here today. I'm also a member of the commission, the Behavioral Health Reform and Innovation Commission, and I've spoke to most of y'all, so I'm not going to repeat that. I want to give you some of your time back. But I just want to say, as Jeff talked about, we have updated support letters that we can give you. I know I've met with many of you, but every week we're getting more and more people to sign on. So please know that we're not done, and I've gotten a couple calls today for more letters as well. I also want to recommend a book called Science Over Stigma. You know, the information about mental health in the last 20 years has changed a lot, and we now have brain scans that will actually show how mental health impacts the brain. So for anybody who doesn't understand that, there's a great book out. It's $30. Finally, I wanted to share, for anybody who's interested, we've created binders for you from the commission that gives you all of the background work that was done. As everybody has said, we've met for a long time, and I wanted to make sure we have this in a Google Doc too, if anybody's interested. Got ones in the corner. I think you guys all know that NAMI Georgia supports this bill. Pre-pandemic, we served over 30,000 people in our throughout the state and across the state of Georgia. We're already up to 18,000 now, and these are people who are experiencing mental health on a daily basis and need this bill to do better. Thank you.
Thank you. She is a lady of her word there. 1 minute and 26 seconds. That's great. Thank you so much. Dr. Ayo Gathing, and I probably did not pronounce that correctly, but Black Rose Foundation, I got that. So,
Yes.
all right, the floor
You were
is yours.
close. It's Dr. Io Gavin.
Sorry.
And I am here as a child, adolescent, and adult psychiatrist and vice president of the Black Rose Foundation for Children. It's a nonprofit that serves children in the state of Georgia by supporting mentorships, scholarships, literacy, as well as wellness programs. We support HB 1013, and I am here to recommend a change that we feel will improve this bill. We believe adding language about opportunities to explore universal mental wellness screening will be in alignment with the AAP, which is the American Academy of Pediatrics, recommendation for a psychosocial behavioral assessment at each well child visit for children birth through 21. In addition, they recommend a developmental screening to include screening for neurodevelopmental disorders and behavioral and emotional problems at 9 months, 18 months, and 30 months. For school-age children, the National Center for School Mental Health considers universal screening in schools a best practice to help identify the strengths and needs of all students, not just those presenting with behavioral concerns. You should have received the details of these recommendations through your Senate email. So we recommend the following revision. In Part 5, Child and Adolescent Behavioral Health, Section 5.5, line 1825A7, services shall promote early identification and intervention to include opportunities to explore universal screening for behavioral health concerns. While we recognize the merits of HB 1013 for all sectors of our state and mammoth job completed by original sponsors and supporters, we believe that including recommended changes to explore universal screening for behavioral health concerns will allow our state to move closer to physical and mental health parity, make the bill more inclusive for all children, not just those presenting with current behavioral health concerns, and place our state at the top in mental wellness indices in the nation, and also provide a best practice in this field of health and wellness. Thank you for your time and consideration.
Thank you. What I'm going to do is I'm going to do questions after we've done testimony, and then we'll do that. Thank you so much. Jan Morrow with John Birch. Did I say that? I think that's John Birch.
Well, good afternoon. I actually am a citizen here representing myself. And as a registered nurse, I don't practice anymore, but I've had a lot of experience in the area of addiction services and working with people in that type of system to see it as a revolving door. And I can see why people want to do something, because it is criminal what is happening across the country, because what I saw were organizations, companies profiting at the expense of the individual. Individuals who did need to have the right type of treatments, the right type of programs, and they're kind of being denied, and they're caught in the system. I found it very intriguing. I did Bible study inside a residential treatment facility in Florida that was secular. I did the Bible study. Very interesting, because the people there, every single one of them had an attorney. By golly, I don't know how that is. And I want to know who's paying for it. So when I look at a bill like this, and I see it's 77 pages, and I see, geez, the government doesn't do a good job in a lot of areas because they're the government. This is about people. Healthcare is about people. And I do really subscribe to having the churches more engaged and involved, as opposed to institutions and additional organizations that are going to be developed in this bill. This is a big concern that I have. So the first thing that jumped out at me is we live in the state of Georgia. Georgia has a constitution. We have a U.S. Constitution. It's pretty small, isn't it? It's not 77 pages even. So I look at that and I say, well, we're like a country. Every state is a country. We do not have to accept federal regulations, laws. We don't have to accept those laws. We have a thing called nullification that is actually in force. And so I don't necessarily agree with some of the testimony here. I don't think that we have to go along with the federal. I think we're smarter than that. And the thing that concerns me the most is you are aligning with the World Health Organization, the organization that we've seen has lied to us on a number of fronts, the organization that is funded by the Bill Gates organization. And I think that that's something that should be a concern. And that's what I want to leave with you, that when it comes to looking at handling issues, I think that we need to not have as much government control, and we need to step that back to private organizations and not aligning with World Health. Thank you so much.
Thank you, Ms. Morrow. We appreciate your insight. Erica Sitkoff and Voices for Georgia's Children. All right, floor is yours.
Thank you, Chairman, for the opportunity to testify today. Good afternoon. My name is Erica Finner-Sitkoff, and I'm the Executive Director of Voices for Georgia's Children. I'm also a licensed clinical child psychologist. So between that and our comprehensive child policy and advocacy that we do on behalf of all of Georgia's kids, I want to thank you both professionally and personally for the work of this committee, and as well as other amazing champions in both chambers for your work this year and in years past on the behavioral health for kids from birth through adulthood. I know there are a lot of people to testify, so I will try and be brief as well and talk quickly. First, we are pleased with the bill, especially the appreciative of the work that Chair Oliver and Chair Jones have done. We support its provisions pertaining to parity in Section 1, medical loss ratio also in Section 1, and in general, we agree with the bill's philosophical direction towards therapeutic supports and solutions rather than punitive ones when certain behaviors or situations cause the engagement of public safety personnel, courts, and others. To be clear, however, Voices does not have a position on provisions regarding assisted outpatient treatment in Section 3 or involuntary commitment also in Section 3, nor do we have a position on provisions creating AOT repository, provided that the repository does not include those under 18 years of age. We are extremely pleased with Part 2 of the bill dealing with workforce development through service cancelable loans and the creation of the Behavioral Health Care Workforce Database. As many of you probably know, we at Voices have spent a great amount of energy trying to assess workforce challenges in pediatric behavioral health. To that end, we have long advocated for such a comprehensive survey of providers as this bill directs. So getting a mechanism in place that can tell us whom we have practicing where and in what fields or specialties is crucial in terms of ensuring we have the scope and scale of providers for kids and adults that this bill contemplates. As we know, even when a child is getting excellent care in one agency or sector, poorly envisioned, coordinated, or implemented transitions between systems, locations, or providers can undo a lot of good. That is why we are also happy about provisions in Section 4 and some in Section 5, which would increase coordination of mental health and disability services for children and youth as provided by the Governor's Office of Health Strategy and Coordination. These requirements to improve case management, supports, and communication between agencies and stakeholders, as well as creation of a unified formulary for mental health and substance use disorders under Medicaid, Peach Care for Kids, and the State Health Benefit Plan are terrific. We are also supportive of Section 5, namely those experiencing dependency, adoption assistance, or delinquency is truly great. The multi-agency treatment for children match team we think has a great deal of potential. And lastly, I'll say that we are generally in favor of Section 6 as well, especially the part that requires coverage for same-day reimbursement for patients who seek more than one type of treatment in one day. Thank you again. Happy to be of assistance as the bill progresses through and answer any questions you may have.
Thank you. Thank you for your big picture, and then I appreciate you diving in there to some specifics. If you get to us the specifics to the authors and to us, that'd be great.
Absolutely.
Thank you for what you do.
Thank you.
Callan Wells. She knew how she had signed up. I'll call out the Helen Robinson, Whitney Griggs, Heather Breeden. I probably didn't pronounce all those correctly, but Georgia Early Education Alliance for Ready Students.
Yep. Thank you, Mr. Chair and members of the committee for allowing me to speak today. My name is Callan Wells, and I am the Senior Health Policy Manager at GEARS, the Georgia Early Education Alliance for Ready Students. We are an organization that advocates on behalf of children under 5 and their families across the state of Georgia. When young children experience trauma, it affects their brain development. The first 5 years are the most critical period for brain development, and disruptions during this time have lifelong impacts. And we know that young children experience adversity and disruptions in their primary caregiving relationships, which is critical to social emotional development. Infants and toddlers are overrepresented in foster care and 3 to 4 times more likely to be suspended or expelled from preschool than their K-12 counterparts. The adult mental health crisis is also affecting our children. Consider this: the 25 to 34-year-old age group is experiencing the most opioid overdose deaths. The average age for first-time parents is 26 to 31. There are developmentally appropriate approaches to therapy in early childhood. This type of therapy is known as dyadic therapy because it includes the dyad of the child and their caregiver. Young children are not medicated, and they are not given a label that will follow them through their whole lives. Therapy for very young children focuses on the relationship between the caregiver and the young child because that is where children find healing and resilience. The Mental Health Parity Act represents a turning point for early childhood mental health in Georgia. For the first time, a bill of this magnitude meaningfully includes young children and their caregivers in the mental health system of care. We have an opportunity to take care of our babies and their families in a comprehensive, easy-to-navigate system of care, to avert mental health crises, and to set our families up for a lifetime of loving, joyful relationships. GEARS supports the passage of this bill with the meaningful inclusion of infants and caregivers throughout our mental health care system. Thank you again for your time.
Thank you so much. We appreciate that. Ms. Robinson's ahead of me. Thank you. The floor is yours.
Thank you. Helen Robinson with the Carter Center Mental Health Program, and I am here representing the members of the Georgia Parity Collaborative, around 40 statewide organizations, many of whom are here today, who've been working together to advance parity and insurance coverage of behavioral health care in our state. And I think it's fitting that parity is part one of this bill because it is the linchpin for improving access to affordable care for families and children and for addressing our workforce shortages. Parity is simply ensuring that both our public and private health insurance plans cover behavioral health care equitably with physical health care. And lack of parity leads to those long wait times and the lack of behavioral health providers in your town, which are related to that lack of parity and reimbursement for providers. Lack of parity leads to children and adults not receiving that early intervention that can prevent a crisis later on down the road. It leads to our families paying out of pocket for needed care, and it leads to parents facing those arbitrary limits on what their children may need to become well. It also, lack of parity leads to the state covering treatment that private insurance companies should be paying for. The provisions in Part 1 of the Act are essential to ensure transparency and accountability from insurers by strengthening our monitoring, reporting, and enforcement of behavioral health parity. The State Department of Community Health and Department of Insurance will regularly monitor parity compliance and take action when violations occur. The Act makes it easier for families to file parity complaints with the state so that we can see the trends. It makes that parity compliance data transparent and publicly available. And it ensures that medical necessity determinations are based on generally accepted standards of care so that, again, they are not arbitrary. And finally, it importantly aligns existing code sections in our state code, which I believe are from the 80s and are outdated, to make sure they reflect current law and current clinical standards. Again, we thank you for your prioritization of mental health this session and for everything that you are doing to eliminate stigma for behavioral health issues. And with that, that's it. Thank you.
Thank you, Ms. Robinson. And she's certainly under. Ms. Whitney Griggs, then Heather Breeden, and then we are at Bethany Shearer and Clint Muller. The floor is yours.
Thank you. My name is Whitney Griggs, and I am the Health Policy Analyst with Georgians for a Healthy Future. Georgians for a Healthy Future is a nonprofit organization that is focused on ensuring that all Georgians have access to the quality health care they need to live healthy, productive lives. We are also a member of the Georgia Parity Collaborative that Helen mentioned and the Mental Health Public Policy Partnership, which was mentioned before. We've been working on the issue of parity for a long time, and we're so excited to see the legislature meaningfully address it this year. Georgians for a Healthy Future is supportive of the bill, and I'm here to speak today on the parity section, Section 1 of the bill. We believe that the parity section was written almost perfectly. The language is strong and it's robust enough to meaningfully improve access to mental health treatment for millions of Georgians. However, we really believe that the parity portion of the bill needs to remain as written. That language is strong, it will protect Georgians, and includes definitions to ensure the strongest protections for Georgians. Representative Oliver kind of alluded to this before, and Helen did as well, but federal courts have said that the parity standard for insurers should follow the generally accepted standards of care, which is what the bill defines. The Georgia law will be aligned with the current understanding of federal law if the bill maintains the standard of medically necessary treatment and follows the generally accepted standards of care for mental health and substance use treatment disorders. We believe that the guidelines of generally accepted standards of care are critical to ensure that insurers' criteria is in line with what physicians and other providers are using to diagnose and treat folks suffering from mental illness or substance use disorders. Thank you.
We're on a roll. All right, Heather Breeden.
We support the bill and will hold our testimony to some.
Okay, so Ms. Breeden's going to hold her National MS Society is going to hold her testimony till later with the subcommittee, and so that comes to Ms. Scherer.
I'll be very brief. My name is Bethany Scherer. I'm here on behalf of the Medical Association of Georgia. We represent over 8,000 physicians across the state in all different specialties. Mental health parity is one of our priorities for this year because it is extremely important that we treat mental health care the same as we treat any other kind of health care, because we can't have true access to care without access to mental health care. We really appreciate the work of Representative Oliver and Representative Jones, and we look forward to working with all of you as we move this bill through the process. Thank you.
Ms. Scherer has a record. She's at 33 seconds. So thank you, Ms. Scherer. Clint Muller. And I may not have pronounced that correctly.
Thank you,
Mueller.
Mr. Chairman Watson and members of the committee. Yes, it's Clint Mueller.
Sorry. Okay.
Clint Mueller, I'm the legislative director for ACCG. We represent all 159 county governments in the state of Georgia. I know most legislators sometimes think that we come here and oppose a lot of legislation, which we do. I hear that all the time about how many bills we oppose down here. But today I'm happy to stand before you and say we 100% are in support of this legislation. This is a top priority for our association. You may ask why. It's already been mentioned today. County governments, we're where the rubber meets the road when it comes to public safety in the courts. These issues are playing out in our local court systems, in our local jails, and our law enforcement officers out there on the street are having to deal with this. And they don't have the tools that they need to deal with it. A lot of these people are winding up in our county jails. They don't belong there. That is not the place to treat these individuals. We do not want them in our county jails. We want to be able to divert them to places where they can get proper treatment. We need more crisis intervention beds. We need more co-responders. We need more training with our law enforcement officers. This is just a significant issue for us in being able to divert these people to where they can get help. Mental health courts, we're 100% in support of expanding mental health courts around the state. We'll do whatever we can to get a mental health court in every part of this state of Georgia. So I just wanted to say we are 100% in support of this and stand here ready to serve you however we can.
Thank you. I appreciate that. Thank you so much.
Thank you.
That's the testimony for today. What I'd like to do is if the committee that's had any questions, and then get the authors to respond, and then we'll set the stage for Wednesday and Thursday. So I think, Leader Butler, did you cut you off earlier? Apologize about that. We're probably on mic number 11, maybe? Okay, thank you.
And thank you, Mr. Chairman. I agree with you when it comes to 20 minutes. You're just about done. The doctor, yes, you. She mentioned in part 5, I wanted the line numbers, and also who should we look for to receive that email that you say was sent out with those points in it.
The Black Rose email.
Excuse me? Uh-huh.
So she can, is this with the Black Rose Foundation?
It is.
Okay, so she can get it to us and get it to me or Caitlin, and we'll distribute it, or Todd,
Okay.
or
Okay.
Representative Jones and Representative Mary Margaret Oliver, and we'll distribute that. Thank you.
Okay, that's good.
Okay.
Okay.
All right.
Thank you.
That was an easy question. Anybody got a tougher question? All right. All right. I'd like to let y'all respond or give us a wrap up, and then we'll set the stage if that's okay. I'm sorry.
I'm on number 2.
All right.
I don't know my bill numbers like y'all do, but our co-responder bill, what was that, 403?
So
have either of you looked at that to compare those provisions to yours, and any input you have onto the, which ones you like the best, or pros or cons of them? We'd love to hear.
Your judge,
Well, I saw him back there, made me think about it, Dee.
Been very active in developing a 403 model. I think your 403 model has a lot to offer. The question in my mind, which we will discuss further, because I think that is a great opportunity to get the best of both worlds, is does every co-responder program have to be aligned to the CSB, or like Brookhaven, could it be somewhat independent? And I just want to look at the plus and minuses of all that.
Okay.
We want to collect consistent data because we're operating in a variety of ways, but there are many aspects of the 403 program that I think are better than what we've outlined.
I concur, and I do think we need to look at, should it be, maybe not ad hoc, but does it necessarily have to tie to the CSBs? And I think that's a conversation I'm going to assume will be in subcommittee, Mr. Chairman.
Yeah, we presented it today and it got voted out of House HHS, and Chair Lady Cooper will be carrying it. And listen, I'm not getting into a posture of Senate versus House. We're discussing mental health and the co-responder portion, and Judge Swetton is back, and I see law enforcement in the back also. The biggest argument that we've had is that whether it's a 80% or 90% turnaround or 99% turnaround. The statistic that fit with me is that when police officers respond to mental health crisis, that they were arresting them, whether that's 88 or 99%, depending on your statistics, of the time arresting them, going to the emergency room, and then going to jail. They turn that around to less than 1%, or up to 20%. And that's the biggest argument we've had. Now, CSB is part of Department of Behavior Health and Developmental Disabilities, which is basically mental health and intellectual disabilities. It is part of that. I was corrected today. I was thinking there were 5 or 6. There are actually 9 of these already in existence. And you're correct, not all of them go through CSB. But I think that the important part was this was a local initiative. There have been grants that have done that, and the sheriffs and law enforcement have embraced it. And they've embraced it because they're not taking these people who have a mental health crisis to jail where they don't need to be, or the emergency room where they really don't need to be. If they need to be plugged in, and not everybody goes to the Behavior Crisis Center. It's a small percentage does, and sometimes they do need that. They reduced the time of writing 1013s down to around 10%. So that's, I thought, was very impressive also. So it's defusing or de-escalating a situation. We have 9 going on in the state of Georgia. If we can put that in a framework to get that done this session, I think that will certainly be a success. And but I don't think they're mutually exclusive by any means. So that was a much longer answer than you probably anticipated. I apologize about that. We do have a couple more questions. The chairman of the subcommittee that will be suffering through this with the rest of us is Senator Burke, and I don't mean that in a negative way. I mean that in a very positive way, I should say that. So, Chairman Burke.
I love backhanded compliments, Mr. Chairman. Thank you for the honor of allowing me to walk this tightrope. And we'll have tons more conversation, but because of the extremely limited amount of time the Senate's going to have to evaluate this and the broad reach of it, I'd really love for y'all to be forwarding or getting to us any fiscal notes or any work that's been done with any of the agencies on what this is going to cost. And I understand at this point in time, we don't have a final bill, but as an appropriator, we understand that all of these initiatives have a price tag, and I can't go forward making these decisions without having some data to understand.
And I will apologize. I'm going to interrupt there a little bit. We did actually request a fiscal note last Friday, and so I think I asked that question from the very beginning, and I got absolutely no pushback, and so I thought that was just an appropriate thing to do, and we'll continue to work with you.
But if they have anything already,
We
you know,
do
that you
have,
have
Okay,
developed.
that's
I'm just
great.
saying,
Thank you. I
send it
didn't,
on.
maybe I was, shouldn't have interrupted there.
Kevin Tanner has been working with the governor and Office of OPB folks throughout the summer and fall, and the House passed a budget Friday morning that put about $120 million into the budget. That is a very good estimate, an informed estimate of a variety of provisions that are covered by this bill.
So that number includes the amended and the big in 23. We've gone ahead. The House Budget Office has been keeping a line item of each part of 1013. They provided that line item to Regina Quick. I believe Regina got it on Thursday or Friday. My apologies for not knowing the exact day. So she has that, and my understanding, Chairman Watson and Senator Burke, is that that information got pushed over to the individuals who are putting together the fiscal note.
Thank you.
I appreciate working together on this. That's great. Yeah, I think I saw another question here. Yes, Chairman Kirkpatrick.
Thank you. As you probably know, we've been working on some of these things on the Senate side also, and we did pass Senate Bill 342, which was our version of the parity part of the bill, and I just didn't know if you all had had a chance to look at it, and if you haven't, I would request that you do, and as we're kind of weighing this. But I did have one question unrelated to that, and that is, I am not clear on, there's infants in the bill, throughout the bill in different places, and I wasn't quite sure. I had heard somewhere that maybe infants had come out of the bill, but can you explain why they, if they're in there for a reason, if they were taken out, and why they're back in?
Have reviewed your parity provision and happy to talk about it ad nauseum, as much as you'd like to talk about it, about where the levers are for enforcement. The science and the focus and investigation and advocacy for children under 5 has really grown significantly, in my view, in the recent years of my practice, of my political life. And it seems to me that we have leaders who are really, as you see, the what is appropriate under EPSDT to determine whether or not a child who is already entitled to mental health services under EPSDT, what is the appropriate age to begin to intervene? We always are told, and I believe it's true, that early intervention helps and is predictive of a better result. Infants came in and out, and I think you're right about that, and I'm happy for a discussion from experts in this area of early childhood development where they think it's most appropriate.
Yes, Senator Kirkpatrick, my Gears spoke to it a little bit, and our understanding of the brain development from birth to 4 is, as you know, much more profound today than it was even a decade ago. We know, for instance, what it means in terms of education, and we know what it means in terms of, at least we believe we know what it means in terms of mental illness. So the idea was, let's go ahead and keep it in. We understand that there is a discussion to be had on it, though, and to Chairman Oliver's point, that is not something that we stand here resolute. We stand here resolute in the sense that we're committed to having a conversation with the Senate about that.
All right, no further questions. I'm sorry, I apologize. There we, all right, 8. All right, does.
Thank you, Mr. Chair.
All right.
Thanks so much for the way you've laid out the high-level look at this bill, and of course, countless thanks to all those who've been working diligently for some years now. I had just two quick points, and one is that in the fiscal note approach and the cost to the state, is there an effort to look at the savings to the state? We're spending money in system after system, silo after silo, coping, not always with the results we'd like with people with mental illness and substance abuse disorder. So that's part of the picture of what are we not going to be, what are we going to spare spending and redirect it in a sense. I mean, is that part of the formulation? Because I think it's real.
It's part of my day-to-day case law. Client's 20-something-year-old son spent 3 years in the Gwinnett County Jail based on an interaction with a cop. When he didn't have clothes on, he's in the middle of the road, and nobody got hurt. But he's 3 years in the Gwinnett County Jail. What did that cost? It cost a lot more than an effective use of crisis money. I think our weakest link in our system may be the crisis units, and to the extent we can divert law enforcement resources, law enforcement money, to help law enforcement free their time away from the repetitive incarceration of mentally ill people, I think we will save some money. But I look at the jail population. DeKalb County Jail, the largest jail in Georgia, this is the largest mental health system in any county in Georgia. What does that cost? And what are we not spending money on as we litigate with the DeKalb County Jail about those inmates' entitlement to special education services, for instance, and entitlement to EPSD screening, for instance? I mean, that's the way we're wasting money on duplication. If we
and you're correct. It's not just it's not the state wasting money. I mean, I hate to circle back to Savannah, but every opportunity I get. But our county, actually, the sheriff and the county commission appropriated money because they recognized that it would, again, the numbers were, if you want to use a general number of 90%, being arrested to 10% being arrested, that is significant. And getting those people in crisis plugged in, whether it's through Behavior Crisis Center or just a follow-up appointment or substance abuse disorder facility, it's the right thing from a mental health standpoint, but it's also fiscally responsible, and I don't expect it to be an issue. All right, so I don't want to. All right, okay.
Just to bring a little more history, we can go all the way back to one of the early years of Governor Zell Miller's, I believe, first term, and he held a conference on the early childhood development and the brain. And it was in those years when we were just beginning to look at that, and from that, and it became something of a punchline. But he set up to have every child born go home from the hospital with
Mozart.
With Mozart, there you go. But the point being that brain is growing and developing.
Is brain development in utero.
Right, brain development.
Right. Thank you.
From day one. I just wanted to.
So I apologize. Athens Clarke County has been a great, and Judge Sweat back there has been great with this, as has Ron Freeman, Forsyth County, Gwinnett, Rockdale, Fulton County, Carroll County, and I'm leaving out others. There are 9 places that have done that, and a lot of them through grants and local. Dr. Al, did you have a question? We're talking too much. You can go ahead. I apologize.
Just a real quick comment. Back to the issue of the freestanding co-responder bill that Dr. Watson put forth. I just want to point out one thing. In this HB 1013 in lines 1515 and 1516, it addresses specifically the issue of utilizing culturally and linguistically capable personnel or materials in the co-responder piece, which, Dr. Watson, you can correct me if I'm wrong. I'm not sure that that's part of the SB 403, so I would just encourage that when we harmonize or however we work out the balance between those two bills in the co-responder piece, that we try to retain that culturally and linguistically appropriate outreach, because that's going to be really important for a state like Georgia, which has a growing immigrant community and a community where people don't speak English as a first language.
Very strong testimony in a variety of ways about the need for some, and law enforcement, because testimony came from law enforcement. How do they deal with training police officers to talk with somebody from another language, another culture?
Thank you for your work.
Thank you, Dr. Al. Any other questions? Alrighty, so that was about an hour and a half. Thanks everybody for their patience. So let me just again repeat. So we're going to have subcommittee meeting on Wednesday and Thursday. The mezzanine at 2 o'clock on Wednesday, and here in 450 on Thursday at what looks like 1 p.m. And what we're doing on Wednesday will be Section 1, which is parity and medical spend ratio or loss ratio, or however you want to term that, and that's about 21 out of 77 pages. Wednesday, full committee. So again, we're HHS. The full committee will be meeting at 1. We're coming on the floor Wednesday. So you know what? We've always got to adapt. COVID has taught us nothing but adaptation, but we may be adapting on that one too. I apologize that because the chairman is giving me a little bit heads up. So stay tuned, but that's we'll be doing Section 1 initially. How about that? And the timing will continue to work out. Thank you so much. Meeting adjourned.